we're going to show you a very interesting case. So Nanda Kumar, please go ahead.
So here is a 57-year-old lady presented with the NST elevation MI, and coronary angiogram showed disease involving left anterior descending and left circumflex artery. The LV function was 48%, and carotid Doppler showed right internal carotid artery total occlusion. The risk factors are diabetes mellitus, renal functions normal, syntax score 12. So this is the angiogram through the radial using 5 French TAG. We can see the RCA is anomalously arising little anterior and little above from the usual position. And this is the left. If you see here again the anomalous origin of the LCA, we can see it is far away from the expected area. In fact, a little at the sinotubular junction, little above and more anteriorly. And coronary anatomy, if you see, there is a LCX lesion, which is a non-dominant LCX, which is actually a culprit lesion. And LAD in the PA cranial view, we can show it's basically a mid-LAD long tubular lesion with the LAD diagonal bifurcation lesion. In a LAO caudal view, looks like proximal LAD is little free of disease. Anyway, we are going to use OCT imaging in this case to assess the proximal LAD disease. I'm going to the carotid Doppler. We can see here in the right carotid Doppler, the internal carotid artery is totally occluded, no flow. On the right side of the screen, we can see the normal left internal carotid artery. And this is the velocity. We can see right internal carotid artery. The peak systolic velocity is 38.25 centimeter per second.
So what we're doing is we wired the LAD and diagonal. So that's the LAD and there's a diagonal disease. So that's what's the major lesion here. We're going to do a balloon dilatation first. There's calcium in that. We'll need to check what we need to do for the calcium, whether it's going to be an IVL or something else. And we're going to do the OCT after the pre-dilatation with a 2.5 millimeter balloon. So if we pre-dilated and now we're going in with an OCT. So we have two diagonals in place and we're going in the OCT. So here's OCT catheter. That seems to go in reasonably. So I'm just pulling the LAD wire back. You can see a little difficulty in getting the OCT because of the calcium, but surely but surely it is going forward. And this is a clear sign that there will be calcium here. So this is where we are, and we get the guiding in. So now we're going to do an OCT with pressure injector. So
Okay, I will take a call.
yes, please.
Calibrate. Cine, please. Inject. Stop cine. So now here I'm beginning with the distal most area. We can see the clear 3-layer structures of the LAD with no block. Here we can see minimal intimal thickening. As I'm proceeding, we can see the block areas come. So I stop. This may be our distal landing zone. This is a distal landing zone. First I'm measuring the distal landing zone. EM to EM, it is 2.65 in a vertical axis and 2.62 in the horizontal axis. So 2.5 is going to be the distal reference. As I'm moving into the lesion, we can see a fibrotic block here. This is because of balloon induced dissections we are seeing extending up to the media. And there is some branch, I think the LAD wire, we can clearly see it joins, and ostium is diseased. The ostium, we can see clearly it is diseased. And as we are moving into the proximal portion of the LAD, we can still see the balloon dissections. And here is full fibrotic block. And again here only I'm seeing at the upper quadrant the 3-layer structure, lower quadrant couldn't see. Still it is block everywhere. We can see some calcified block here, maybe from 4 o'clock to 7 o'clock. And as I'm proceeding further into the LAD, circ joints. So all the way it is extending up to the ostial LAD. Left main is reasonably free of disease. So where we are going to stop is the question. I think predilatations are more than adequate. Only we need to find a ideal landing zone in the proximal portion. So
Okay, so
distal
what?
is a good landing zone. So maybe we have to take 2.528 stent, and we have to take a 3 post dilatation. The only thing is diagonal ostium is little disease. Maybe we can do a pre-dilatation, put
Sure.
a provisional single stent strategy, then we will take a call after
Okay,
the
so
stent.
two issues. One, that this is not a calcified lesion too much. It's only in the proximal LAD, so we don't need an IVL here. So what we'll do is we'll just do the diagonal first. Get me the same 2.5 balloon, please.
So at this portion, we can see the calcium from 3 o'clock to 6 o'clock. But this is spotty calcium. The thickness of the calcium is 680 microns. But the calcium arc is not 270-degree, and it is more deeply situated calcium. Hence, no further calcium modification is required.
Okay. So basically, what Dr. Nandakumar is saying that it's spotty calcium, not deep plates or nodular calcium where we need some debulking strategies. A plain balloon with a 2.5 was good enough. Yeah. And we're going to do the diagonal because the diagonal is disease. Can you show them the diagonal as it?
So I am moving towards the diagonal ostium. We can see the wire. The 12 o'clock position is the diagonal wire. It's just entering into the diagonal. We can see this is clearly the diagonal ostium is diseased, but it's a focal disease, which means it is not extending beyond 5 millimeter of the ostium. Hence, maybe we can get away with only the dilatation and provisional single stent strategy. If at all, if it is going to get compromised, then always we can go for a tap as a bailout. That's what I
Just
feel.
go ahead. Yeah, it's fine. Go up. It's just at the origin. I'm going to go at low pressure, long dilatation with a 2.5 balloon. Just keep it there, please. When you do a bifurcation, what are the indications that your vessel will close on you? One is when there's disease in the ostium. Second, if the angle is acute and there's a spiky carina, which can land up with closure. So we have pre-dilated the diagonal. We'll take a small cine shot before we go in with the LAD stent. Okay, so what we're going to do is from the proximal to that, as you said, there is some disease in the ostium of the LAD. You think we can leave that alone, isn't it?
Yeah, we will do a pre-dilatation because during the stenting, definitely the spiky carina is going to close at 1. So I feel we will do a 2.5 pre-dilatation so that the chances of closure of the diagonal is little
Yeah, so
less.
we did the dilatation now and we're finished with that.
Okay.
So now I'm going to stent. I'm just asking you the ostium of the LAD. Do you think we need to cover that?
No, no, no.
So you can see that the diagonal is open, but not good enough, but that's okay. You don't expect with a ballooning. It was a 2.5 balloon. You went up to nominal. Didn't want any dissection there. So as per the length, we are using a 2.528. Small check, please.
And we will do a pot with a 3 millimeter balloon.
Small check, please. Okay, that seems to be all right, I think.
Yeah.
What do you think?
We'll check once again in RAO caudal.
RAO caudal, please. So the issue is that if we do have on the OCT some proximal disease, small check. Okay, I think that's good. Yeah, go up there. Yeah, go back to the other view. Please, yeah. Go to nominal. Okay. So we have covered the mid and proximal part of the lesion at the diagonal. Go up, please, once again. And then we'll check whether we need anything to be done in the ostium part. And we keep the 2.5 balloon ready, sister, and a 3.0 for a pot for the eddy plate. There is some compromise of the flow. Anyway, I think we'll do the pot. After that, we'll decide what to do to recross.
We'll take one image in LAO caudal and see what.
Okay, let's take an LAO caudal.
I think it looks good.
Yeah, it looks pretty good. So let's do the pot and then see what you have to do for the recross. So give me the 3.0 for the pot. And then if the diagonal has a problem, we'll recross it. There is some slow flow. Yeah. So we'll take another wire ready, please. So I need a hydrophilic wire for crossing. So you can see that the proximal LAD looks good. The proximal stent looks good. The distal stent looks good. So we're just going to do a pot and see if the diagonal flow improves. If not, we'll cross into the diagonal and do a kissing. Sometimes the pot itself will open up the diagonal because the stents will get opposed to the side of the bifurcation. So we can sometimes get a good flow there. Are we ready for a shot, Ajit? Yeah. It's still a bit slow flow, but I think it's better. Go to the other view, please. Okay, just give me a wire. Let me recross into the diagonal. So we're now going to go into the diagonal. So we go to the LAO caudal, please. Guide is directing to the circ, so I need to give a little bit of a curve. So I'm going to use the other wire as a marker to get into the diagonal. So we go into the LAD first distally. Okay, that's in the diagonal. And then we pull off the other diagonal wire. Get the same balloon, please. 2.5. Hopefully it'll cross. If not, we'll need a New York tour. Keep it New York tour ready. Okay. Gently go up there. Okay, go up, please.
I think our pre-dilatation helped in
Yes. It didn't
open
completely
the
close
studs.
off. Just keep it at 6. Yeah.
Keep it for some time to opposite flaps, 5-10 seconds. Yeah, it's okay. We can deflate.
Deflate, please. So now what I'm going to do is just push the deflated balloon down into the diagonal and small check on the LAD. The LAD wires. Wire. So we'll try to get the LAD wire down. Okay. And let's get the 3O LAD on this one. 3O balloon on that one. So what I'm going to do is now get the other 3O balloon into the LAD and then do a small kissing across the diagonal. So we've done the pot, we've done the bifurcation kissing, and now I just want to take a shot and possibly an OCT. So the wire is facing the LAD, the circumflex. Let's take a cine first. Can you Ajit take a cine by the time I wire this? Yeah, take a curve here. Looks pretty good. There's a little dissection on the diagonal, but I'm not going to stem that. The flow is good. What do you think, Nanda?
Yeah, we will see in the OCT. If it is a no flow limiting dissection, no need to stent that one.
Okay. Ready? I think the LAD is okay. The diagonal is flowing well. There is some pinching, but I'm not going to chase that. We've already, what do you think?
Yeah, we
Nanda?
have to take a OCT
Yeah,
and
we'll take an
diagonal flow. I'm
OCT and
happy.
okay, take the OCT down, please. So what are the things as we boot in, Nanda, you're going to look at?
So I think I'm going to look at the distal edge for any distal edge dissection and the expansion. Then coming to the lesion area, I'm happy with 80% expansion in this particular case. And I'm going to look at the diagonal ostium, how it looks, is there is any flow limiting dissection is there or not. And the proximal edge, how it is expanded. Since it is a 28 millimeter stent, I think maybe we can divide the stent into two half before the diagonal and after the diagonal, and we can measure the expansion. And at last, we are going to see the ostial LAD, whether during this catheter manipulation, any block has got disrupted or not. Okay, everybody ready?
Port is ready, die
Yeah,
is ready, pressure injector
I'm
on.
taking a call, calibrate,
Yes.
cine, inject, stop cine,
Okay, Nanda, I think we got some good pictures. So
So the first thing what we are seeing at the first glance, the stent divided into two halves, and this is a 28 millimeter stent, right, sir?
yes,
So the length here it comes 30 millimeter, maybe the 28 millimeter elongated to 30 millimeter. The expansion of the proximal half I'm bringing before diagonal, after diagonal. It shows 89%, which is a good expansion. The distal half 92%. If you see exactly, if we divide the stent, actually it is not dividing at the diagonal, hence it is showing 69%. But if we place it before and after diagonal, it's showing 89 and 92%, which is well expanded. The next part is I'm going to check at the both edges. This is the distal edge. As I'm moving away from the stent, it's clear, no edge dissection, at least for 3 to 5 millimeter. And it's a well opposed stent. Expansion already we have covered. And this is a proximal edge. Beyond the proximal edge, I'm moving. There is a small edge dissection we can see at 12 o'clock, but it's a minor edge dissection, and which is not extending into the media, neither it covers more than one quadrant and not going beyond 5 millimeter. Hence I think we need not address anything at the proximal edge. Next, it's coming at the ostial of the LAD. The blocks remains as such without any disturbance because of our catheter manipulation or our balloon, everything. I am just measuring the MLA once again, because this is a clear picture rather than the previous picture. Here it is 4.31 millimeter square. It's clearly above 4 millimeter square. No need to address it. And the next point is at the bifurcation part. So we can see at 2 o'clock position the diagonal, the circle is there. And as it joins, there is a pinching definitely. So this is the ostium of that mild pinch, but I think it's uh, it's good enough. So let's check with the 3D bifurcation software. So here we can see clearly the ostium is nicely opened, and if you rotate and see here, you can see the diagonal. I think the diagonal is nicely open here. Another important thing I want to
take a
show
shot.
you is this. Because of the kissing, we can see how nicely in the stent that side
Yeah.
strut is opened here in the stent only view. So for the future access of diagonal, it is good.
I think what we learned, Nanda, if you can just repeat all what we did for the LAD for the benefit of us and for the audience.
So fluoroscopically, it's a anomalous LCA, and there is some calcium was seen fluoroscopically. So we did a predilatation with a 2.5 balloon at the LAD diagonal bifurcation, and we did a OCT, which showed two important things. The calcium is only spotty calcium, doesn't require any calcium modifications. The another thing is the LAD diagonal bifurcation angle, it's a spiky cranial angle. There is a higher chance of closure, hence we predilated previously the diagonal to get the access easily after the stenting. And we got the clear idea of what is the distal reference diameter, proximal reference diameter. Though there is a blocks are extending up to the ostium of the LAD,
0.5 balloon.
we found a good landing zone at the
2.5 by.
mid portion of the LAD, where the 180-degree arc of EM is visible. And we sized according to the distal reference diameter, and we did the pot according to the proximal reference diameter. Then we finally checked with the expansion, dividing before the diagonal, after the diagonal. The before the diagonal, the expansion is 89%, and after the diagonal 92%, which is a reasonable good expansions, no maloppositions. And here the OCT, we can see the clear images of the stent only view, what are all the connectors points, and how the LAD is nicely opened. I think at the end of this thing, after this seeing the image, we can go to the bed happily.
Okay, so we've got the wire across, and yeah, yeah. So thank you very much. And the idea was to show the LAD under OCT. And here we will thank everybody for joining for the case, my colleagues, my nurses and staff. And now we're going for the circumflex. So thank you very much for joining us.